Hello, I'm David. I'm currently an F2 doctor in London, and today we're going to be doing another scenario in the Oxford Medical Simulation Programme, which is a virtual reality piece of software supposed to be used for training healthcare professionals such as doctors, nurses, medical students, etc. Feedback from the last time I did this was that because I was talking over patients and the nurses and being a bit quick, it was quite hard to follow my thought processes. So this time, I'm not going to do any speed running. I'm going to talk through things properly so that you can understand what I'm thinking, and we're just going to have to accept that I'm going to get marks deducted for being a bit slow. But that's okay. So without further ado, let's start up the scenario. So let's wait for it to load.
Hello, doctor. We have a new patient, Emma Wilkinson. She's a 33-year-old female who's come in with her partner, Barry. She is very confused and a little agitated. I think we've seen her in the ED a few times prior to this. Could you come and see her urgently, please?
Okay, so a reminder, that's the simulation time,
Hello there,
and the white
Emma.
dot is the cursor.
I'm going to be the doctor that's looking after you at the moment. What's brought you to see us today?
Got some monitoring equipment on.
I don't want to be here.
I can't yet.
I just want to get home.
I can understand that. You're in hospital at the moment because you're not feeling well. We'd like to get you feeling better soon.
Right, let's put on the monitoring equipment and let's reassure her, because reassuring patients is
You're
very
in
important.
hospital at the moment. We're going to do some tests, give you some medication, and hopefully have you feeling better soon.
That's the monitoring in place.
Thank you. And let's find out what she's come in with. Presenting
Can
complaint.
you tell me about what's brought you in today?
Oh, Doc, I just feel weird, like...
Okay, so she's not giving much in the way of history. Let's try history presenting
Can you
complaint.
give me the background to what's brought you in?
Oh, I'm not sure. I'm not really feeling well. Barry, could you help?
So let's ask the carer.
I'm happy to speak to you about things if you feel it might be more help.
Can you give me some background as to what's brought Emma in?
Emma called me this morning and was slurring a bit on the phone, so I went round to her hostel. She seemed quite worked up and sweaty, and I was worried about her, so I brought her in. She does overdo the alcohol, Doc, and uses drugs occasionally. But she swore to me she hadn't used anything this morning. She skips meals a lot, which has been worrying me.
That sounds right, Doc.
Okay, and let's talk about past medical history.
Does she have any known medical problems?
As I say, Doc, I know she's been seeing some doctors for her mental health, and she sees her GP quite regular-like. She injects stuff that she gets from the GP and takes some tablets, I think. You might be better calling her sister about it, as she has a better idea about these things.
Oh, Doc, I just feel weird, like...
So the most commonly injectable drug is usually insulin. So let's check on the computer, see if we can see her medications. And she does indeed use insulin. She also uses olanzapine, which is antipsychotic, and disulfiram, which is a drug to help people get off alcohol. Let's have a look at her medical history while we're here. Type 1 diabetes, schizophrenia, IV drug abuse, alcohol misuse, and malnutrition. So that's a really bad combination, because people with type 1 diabetes, if they don't take their insulin, then they get into trouble. And if they do take their insulin but don't eat, then they get hypoglycaemias. And the symptoms she's describing, the sweatiness, those are the autonomic symptoms of hypoglycemia, which precede the more serious neurological symptoms like drowsiness and coma. So let's ask about allergies.
Is Emma allergic to anything?
She's never had any allergies that I know of.
No, I'm not allergic to nothing.
And social history. Where does she live?
Can you tell me a bit about Emma's living situation and lifestyle at the moment?
I won't lie, Doctor. Emma's had a pretty chaotic life these past few years with her mental health stuff and the drugs. But she's really been trying hard these last few months. She's living in a hostel at the moment, and they're happy that things are improving. There's been no job for a wee while, but I know Emma was talking about going down the job centre. No one in the family, aside from one sister, goes near her.
Don't talk about family, Baz. Just don't talk about them.
Can you tell me, does Emma smoke, drink or use recreational drugs?
She smokes a bit, Doc. She was using heroin, but not for a few weeks. I think she's been cutting down with the GP's help. She also likes too much vodka, but she's trying to stop that too.
Please, just let me sleep now.
So remember, the sweatiness and the agitation could also be agitation from withdrawal of any drug, really. So that's important to consider. Right, we're going to, by the way, I have noticed that these observations are not what we want. We're going to do an A2E assessment first. So let's start with the A, which is the airway. So that'll be here. Now, in real life, I wouldn't normally look at the airway in a patient like this because she's talking, so we know her airway is patent. But it's good practice to always look in and make sure there's no obstruction.
Airway patent, no stridor.
And now we're going to go on to B, which is breathing. So we're going to auscultate the chest and make sure there's no abnormal sounds. Okay, and it's sounding the same on both sides. And looking at her SATs, they're within range, 94 to 8%. Are they going to drop at all? Doesn't look like it. Fine. So then we're going to go into C, which is circulation. And we will examine her capillary refill, which will tell her about the circulation in her peripheries.
Cap refill time is 3 seconds.
Okay, so that it should be less than 2, and that tells us that she's peripherally shut down. We're going to have a listen to the heart sounds, and while we're doing that, I'm going to point you to the fact that she's tachycardic at 115, and her blood pressure is very low. So we're going to get in a cannula. I'm going to ask the nurse to do it, and while we're at it, we're going to get them to do blood tests. And there's no need for blood cultures because she's afebrile and there's no complaint of any infection. Although we can consider blood cultures at a later
That's
point.
the IV access in place.
Okay, and now because her blood pressure is that low, we're going to get in a bolus of fluid, and she's not got any heart failure or any conditions which would stop us just putting in a big 500ml bolus.
Those
So we're going to do
fluids are
that,
up and running. I'll let you know when that bag's finished.
and then we're going to do a VBG,
That's done. All
Okay.
the relevant tests are ordered.
and then as part
I'll
of the
get them processed right
we're going
away.
to check the hydration status. We're also going to, what can we see here? Let's
Any headache,
ask about the central nervous
dizziness,
system.
blackouts, visual problems, numbness or tingling?
I have a bit of a headache like, and my eyes feel like they're swimming.
I'll make sure that's taken to the blood gas machine right away.
Okay, fine. So let's check your hydration status. So what I'm doing here is checking the mucous membranes to see how dry they are. It's not actually a very sensitive test, especially if they're wearing
Oral
oxygen.
mucous membranes are dry. Dentition in good condition. No alcohol apparent on breath.
Okay. Now, also, while we're on fluid, she's alcoholic and she's malnourished, we think. So we're going to give her some vitamins. And in patients like this, we always give
Doctor, the VBG results are back.
Fabrinex.
They're on the desk.
Nope. Where is it? Nope. Is it here? Where is it? Oh, electrolyte balance? Nope.
That bag of fluid has finished, Doctor.
Look there. Where is it? Medications by body system again. Central nervous system. Got to be that. Substance dependence. Parenteral vitamins. There we are. So we're going to give her that.
That's given, Doctor.
Okay, and then we're going to press on with the R82 assessment. So the next is disability, which is the nervous system. So we're going to check the pupils, and then we're going to do a blood glucose, or more accurately, we're going to ask the nurse to do that.
Pupil size normal at 4mm. Equal and reactive to light. No scleral icterus.
Okay,
Patient does subjectively report blurred vision.
Fine. So this is less likely something like opioids, toxicity.
Capillary blood glucose is 2.0 millimoles per litre, Doctor. That's registering as very low.
Okay, so she's hypoglycemic. Also note that her SATs are low, so at this point I'm just going to stick her on 15 litres non-rebreathe, which is the go-to for an acute scenario. Remember, you can titrate down later if need be, but hypoxia is going to kill someone first, so you always put them on 15 litres in an acute scenario. Right, so she's hypoglycemic. She's agitated. Is there anywhere where we can assess her cognition? Let's see, I think perhaps that. Nope. Other exams? Nope. Okay, fine. Well, in any case, let's do a urine dip. Let's make sure
That's a
she's not
urine
got an
dip done.
infection.
It's positive for ketones only. You can
Okay.
see the results on the computer.
So the ketones, that tells us that she is malnourished because that's a marker of starvation because you produce ketones when you're burning a lot of fat very quickly. And the VBG does show a very low glucose too. So we need to get some glucose into her rapidly. So let's be good doctors and look at the guidelines. Adult hypoglycemia. Is the patient able to take oral glucose? Probably not, because she's quite agitated and she probably won't know what to do with it. We could try it, but I think since we've got IV access, let's just go with this. So let's give 100 ml of 20% glucose over 15 minutes. So no additive, and wait, I think it's probably in the medication cupboard. Endocrine hypoglycemia, here we are. And let's give it that.
That's given, doctor.
Okay, fine. So let's update the nurse.
I'd like to take a moment to update you on the current clinical plan for Emma, if now is convenient for you.
Okay, thanks for updating me on the situation and progress.
And we'll update the carer.
Let me update you on what's going on at the moment.
Thanks for that, Doctor.
Fine. So we think, to summarise, that she's hypoglycemic because she's probably been using her insulin even though she's malnourished. And therefore she's been giving a dose of insulin for an amount of sugar she's not actually taking in, and that's why she's got low blood sugar. And that's made her feel the way she's feeling. The drug abuse probably also doesn't help. So now we've done all of this, let's tell our senior, see what they say.
You sound like you've got this under control. Keep a close eye on Emma and continue monitoring her blood sugars to ensure she is responding well to our management. It will be worthwhile asking the diabetic team to review her if you haven't already, and also alert psychiatry to the fact she is an inpatient at the moment. Well done. If you're happy she is stable and no further management is required, you can move on to your next patient. I'll be down to review shortly.
So just to complete our A to E assessment, I would normally do an abdominal examination, and I'd check the temperature there, 36.6. I could also look at the skin, which I'll do quickly. Okay.
I've completed a full skin exam, and there are some historic track marks on the flexor surfaces of the arms and in the groin region, but no new sites obvious and no related abscesses or cellulitis. There is no evidence of jaundice. The patient does have decreased skin turgor, suggesting dehydration.
So those marks, the track marks, are from her intravenous drug use. Fine. So I'm not going to do the abdominal exam on the temperature because we know what the cause of her symptoms is. So I'm going to call the diabetes team, and I'm going to
Emma
do
is a
another blood
patient
glucose.
well known to the diabetes team. You have managed her well given her very serious acute presentation. Continue to monitor Emma's blood glucose levels as these will change with treatment. We will come and review her on the ward when she is stable and provide an early outpatient review for her. Thanks for letting us know.
Capillary blood glucose is now at 5 millimoles per litre, doctor.
Right, well that is within normal range, so we fixed her. Very good. So there's a few other people we want to speak to, which is psychiatry.
Hello there. Yes, I can confirm Emma is under the psychiatry team for management of her schizophrenia. She's not always had a good history of engagement with us, but her schizophrenia has been stable for around 6 months since commencing olanzapine, and I get the impression she's been trying to turn her life around a bit. We'd be happy to review her once she's medically stable, but it doesn't sound like you need our input at the moment.
And then it's probably also a good thing to get her social worker involved given her living situation.
Thank you for letting me know Emma has been admitted. I know she's living in homeless accommodation at the moment. When she's feeling more up to it, I'll come down and assess things with her. It might be that we can provide some temporary support on discharge, as she's a vulnerable adult.
Fine. So I'm going to be very quick here now, just because simulation time's running out. But as you can see, her observations have stabilised, her glucose is back to normal, and we've fixed her. And we've updated everyone that we need to update. So I can talk a bit more about things afterwards, but let's just get out of here now. So there's questions. So psychiatry, social work and diabetes team, we've done that. Likely contributed to hypoglycaemia. She's not been eating, she's been using insulin, and she's malnourished.
Response noted.
Okay, and let's get out of here. Just in time. I don't actually know what happens if you run out of time in the simulation. But it's better not to find out. We are going to get docked marks for being so long, for taking so long in this scenario, but you know, it's better to explain things. So here's our self-reflection bit. If you look around, it's just sort of a weird netherland or void. And I think there's running water if you listen carefully. Anyway, you get asked the standard feedback questions. What went well? What could you improve? What would you do next time? Okay. And then it should exit and take us to this page. So, diagnosis, hypoglycemia, secondary to alcohol use, and continued insulin use despite low food intake, as we said. So this is our case summary. She has type 1 diabetes and uses insulin, but she's not been eating. Clinical findings down here. Ketones, signifying starvation, hypoglycemia. We did the A2E assessment, we took a history, we took the appropriate collateral history, i.e. talking to her carer, and we looked at the glucose and ketones. Okay, we didn't do blood ketones actually, but there's probably no pressing need to do that. We did labs, we didn't really look at them in the real world. The formal lab bloods wouldn't actually be back for a good few hours, so it's more realistic actually not to look at them. And again, we didn't look at did we look at urinalysis? I can't remember. I think we got told the results of them by the nurse. We gave fluids, we gave oxygen, we gave Pabrinex and IV fluids. Pabrinex is actually a brand, the parenteral vitamins. It's just a vitamin B complex plus vitamin C, I think. It's also known as a banana bag because it's a big yellow bag of fluid. And just looking down here, we told the right people. Well, we could have told the GP, apparently. And general learning objectives. Again, as I said last time, I really don't think this simulation software teaches you how to do these things, because if you want to reassure the patient, you just click reassure patient. You don't actually have to do any reassuring or use any communication skills. And if you want to talk to your senior, you don't actually have to talk to the senior and use the S-bar method to hand over and like make a sensible suggestion about the diagnosis and plan and do doctoring. So it's a bit weird, this. It just teaches you to do the actual medical stuff, which, I mean, you shouldn't need a simulation to teach you, really. That's what medical school is for. So as I said last time, I think this would be better suited to medical students rather than doctors, this whole simulation software. Learning objectives. Yeah, I mean, I guess we do all of that. And again, funded by Novo Nordisk, which are a pharmaceutical company that make insulins. So let's see. We have again our feedback of what we did and what time in the simulation time we did it. Did all of these things. Oh, I've just remembered one thing we didn't do. We didn't wash our hands. So something that just is second nature to you, like washing your hands, that you just do in real life without even thinking about it now. It's so easy to forget in the simulation software. Yeah, Pabrinex is indeed vitamins B and C. We did the urine dip. We looked at the guidelines. We spoke to senior, psychiatry, social worker, diabetes team as well. It's not on there for some reason. Okay, efficient patient management. As we said, we accepted that we were just going to lose marks for being very slow with this. Hand hygiene. We didn't wash our hands. Always remember to wash your hands, even in software simulations. Update patient. We didn't update the patient. So, key point, even though we updated the carer, we should have updated the patient even if they are agitated, because you don't know how much they're going to understand. Abdominal exam. I did mention that normally I would do an abdominal exam if it were real life, but I was a bit scared that we were going to run out of time, and I don't know what happens when the simulation time ends. And the diabetes team, I'm pretty sure we did phone the diabetes team. I suppose watching this back we'll have to find out. Glucose therapy, you did not give appropriate glucose therapy to this patient. I think we missed out the long-term carbohydrates because we got too hung up on the acute management. So let's see what it says. Emma is high. Yeah. So this is an important point. Why was I giving 20% glucose rather than 50%, which has obviously more glucose in? It's because it buggers your veins. Depending on which trust you're in, it's either 10% or 20%. My current trust is 20%. It does make more sense because 10%, well, there's 10 grams of glucose in a whole litre of 10%, so it's nothing. I am glucagon as if they're unconscious, and it doesn't actually mention anything we didn't do here that we should have done. So I do think that it was referring to the long-term carbohydrates that you give because the effect of the insulin may persist above the time of the acute scenario that we're managing the patient for. So if you treat the hypoglycemia but don't give them long-term carbohydrates, eventually they'll just go straight into hypoglycemia again. But as I say, time was running out and I had to just finish off because otherwise the simulation would have just ended and we wouldn't have had time to talk about all of the stuff we did. So 67%, 14 minutes. Not exactly a speed run to say the least, and not our 100% from last time. But, you know, that's what happens when you don't speed run things and when you have to talk loud. So this is interesting. Last time I couldn't show you how it gives feedback on things you didn't do but should have done. Whereas this time I can show you what it does and it tells you what the score is derived from. So I think different things are weighted differently. So I suspect that not washing your hands is weighted higher than, not doing an abdominal exam, something like that. So that's the rationale for doing an abdominal exam, by the way. I mean, liver disease, well, we would have seen that on the LFTs once we'd got the bloods back. Right, and then you can write some reflection. So I liked that scenario. It was a bit off the wall compared to the other one, which was a very textbook diabetic ketoacidosis. And it did indeed teach you to take a more holistic approach, not just thinking about the acute medical problem, but about the surrounding problems, such as the social situation, the malnutrition, the drug use. So I suppose it does fulfill the learning objectives of teaching you about that. But again, communicating effectively, being able to communicate effectively is not the same. Escalating and referring appropriately, I mean, knowing to click senior and then to contact who your senior tells you to contact, I don't think that really ticks that box. Applying clinical knowledge, I guess, yeah. Clinical decision making, yeah. I mean, again, I think this is the key thing that this simulation teaches, if anything, the decision making. And actually, the decision making is what makes the doctor, because you could train any random person off the street to do a procedure. What makes the doctor is the ability to weigh up all the information and use their extensive background knowledge learned over years of education and to make a decision. And that's the main thing. So that's all this stuff here, really. So it'd be really interesting to see what the general learning objectives are for other healthcare professionals. Let's see. I think if I logged out, then we go to the main website. I think I'm going to have to type in. We can see who they target simulations at. So let's see. Solutions, the nursing educator, medical educator, sim sense manager. So it does look like it's aimed just at nurses and doctors and students thereof. So you can see all their demos here. And unfortunately, our simulation head for our trust has said that they won't be continuing with this software, but we are going to get a couple of new scenarios from May. So yeah, watch this space. Thank you for watching. And if you have any comments or suggestions, please subscribe and comment down below. Thank you.